I'm going to discuss some macroeconomic and demographic drivers of public hospital expenditure. Essentially in this work, what we're doing is we're going to use outputs from the Institute's demographic and macro models as inputs into our healthcare model, Hippocrates. So we're kind of trying to link various models in the Institute together. Looking first at demographic scenarios. Just by way of background, Ireland's demographic profile is somewhat unusual within the wider EU. Ireland has experienced stronger population growth. For example, over the 20-year period 96 to 2016, the population in Ireland grew by 31% compared to just 6% in the EU. Ireland also has a relatively younger demographic structure. So for example, around 13% of the population is over the age of 65, compared to 19% in the wider EU. However, the population is aging. So over that same 20-year period, 96 to 2016, the population over the age of 80 increased by 64%, which is more than double the growth in the overall population. And this aging of the population will continue over the projection horizon. So our approach in terms of modeling demographics is to use a cohort component model, which we have in-house. And essentially here you begin with a base year population and project it forward by sex and single year of age for each year on the basis of assumptions around the components of population change, which are fertility, mortality, and migration. I'll talk about the detailed assumptions in a moment, but just to note, we've adjusted our mortality rates in the short term to take account of the deaths associated with COVID-19. So one of the features that's a bit different about Ireland compared to other countries is that migration is the main driver of population change in Ireland. It is also the most volatile component and therefore the hardest to project. Flows are very sensitive to economic conditions, both at home and abroad. So we link our migration projections to projections from our macro model. And just an important point to note, even though these flows are quite difficult to project, migration predominantly affects the 15 to 44-year-old age group. So, so it has a limited impact on older age cohorts over the projection horizon, which is important to bear in mind when we're looking at healthcare demand. So in the report, we examined three demographic scenarios: the central scenario, a high and a low population scenario. In terms then of some of the more detailed assumptions underpinning each, on mortality across each scenario, we expect to see improvements in mortality. In our central scenario, life expectancy at birth is expected to increase for males from 79.5 years to 83.5 years by 2035, and for females from 83.4 to 86.5 years by 2035. And the improvements are stronger in the high population scenario and weaker in the low population scenario. But across all scenarios, we do expect to see improvements in mortality. On migration, I've mentioned it's a volatile series. Net immigration was just over 33,000 in 2019. We've adjusted net migration figures downwards in the short run, not least because of the weaker macro environment, but also because of the nature of the public health shock. It's reasonable to assume that migration will be lower in the short run because of travel restrictions, lower confidence, uncertainty, and so on. So in our central scenario, migration, net in migration comes down to around 5,000 per annum in the short run and averages out at around 10,000 per annum over the more medium to long term. Migration flows are stronger in our high population scenario, averaging around 25,000 per annum over the medium to long term, and somewhat weaker in the low population scenario, averaging just around 5,000 per annum over the longer term. On fertility, the total fertility rate, which is roughly the average number of children per woman, we assume it's unchanged at 1.7, that the current rate in our central scenario. It rises to 1.96 in our high population scenario. That's still below the replacement rate, and declines to 1.6 in our low population scenario. That's the sort of prevailing fertility rate in the EU. So this is a population pyramid which shows the age structure of the population, with females on the right part of the graph in green, and males on the left. And the bars in the graph show the percentage of the population at each year of age, and year of age there is on the vertical axis. So when we apply the assumptions from the previous slide and look at the age structure in 2035, so in 2035, these are the unshaded bars, we can readily see the aging of the population. The age structure shifts up. So the old age dependency rate, that's the ratio of those over the age of 65 to those 15 to 64, increases from 0.21 in 2018 to 0.31 in 2035. So the age structure is changing over the projection horizon. And this graph is for our central scenario, but it's a similar pattern in each scenario. So in terms of overall population increases and growth, the population is set to increase from 4.9 million in 2018 in our central scenario to 5.4 million by 2035. And this corresponds to annual growth of around 0.6% per annum. In the high population scenario, it reaches 5.8 million by 2035. That's growth of around 1% per annum. That's closer to the growth that we saw over the 96 to 2016 period. And in the low population scenario, the population is expected to reach 5.2 million by 2035. And that corresponds to annual growth of around 0.4% per annum. And across the different scenarios, migration is the main driver of the differences. So that's the sort of the overall picture for population growth over the period. In terms of changes in the age structure over the projection horizon, the number of older people is set to increase. So now around 1 in 7 people are over the age of 65. By 2035, 1 in 5 people will be over the age of 65. And in our central scenario, total population growth between 2018 and 2035 is 11%. It's over the entire period. And it's much higher for those in the older age groups. So it's 61% for those over the age of 65 and 105% for those over the age of 80. So turning now to our macro scenarios, which we use to model the non-demographic drivers of hospital care expenditure. So just by way of background, the pandemic is a public health shock that's having adverse economic impacts. It's not a traditional economic shock. It's having very uneven impacts across the economy. So while the economy has suffered a massive shock affecting key aggregates like consumption, domestic demand, the traded or export sector has been relatively much less impacted. The economic outlook, especially over the short term, is extremely uncertain. It depends on a range of factors that maybe we can't say a huge amount about, including the development of the virus, the severity of continued and/or new containment measures, the success of these measures in terms of controlling the virus, the rollout of the vaccine, and the behavioural response of consumers and firms as more normal activity resumes. So in the report, we looked at two alternative macro scenarios labelled recovery and delayed recovery. And so our approach is to replicate the economic shocks associated with COVID-19 in our macro model Cosmo, and to model potential recovery paths for the economy. The main channels we focus on are production, employment, consumption, investment, and a weaker global environment. However, the timing and speed of any recovery is difficult to evaluate because of the extraordinary nature of the shock and the various unknown factors mentioned earlier. So apologies if the sound gets a bit distorted. I've construction work going on outside my window. I'm assuming it's essential construction. So a broad overview of the scenarios. In our recovery scenario, there is some rebound in production and employment in the non-traded sectors. These are the sectors that are more reliant on domestic demand in the short run, and activity returns to where it otherwise would have been by around 2023. In our delayed recovery scenario, the recovery in the non-traded sector is pushed back by another year. And it also incorporates some scarring effects, whereby some of the losses in employment and output are permanent. So in both scenarios, growth is severely curtailed in the short run. Over the more medium term, out to 2025, the economy grows quite strongly as the effects of the pandemic wane and some lost ground is made up, and then the economy reverts back to kind of trend growth. So over the period that we're looking at here 2019 to 2035, real output growth in both scenarios is expected to average around 3.7% per annum. That's a broad overview of the macro scenarios that we looked at for this report. In terms of inputs into the healthcare expenditure model, in Hippocrates, projections of the pay component of unit costs are based on projections for nominal wage growth in the government sector from Cosmo, and that's projected to be around 2.5% per annum in our recovery scenario and 2.2% in our delayed recovery scenario. These projections are consistent with long-run historical wage developments in the health sector. Then because of the uncertainty around the economic outlook and the importance of these projections for aspects of healthcare spending, the report also considers a sensitivity around a public sector pay freeze. And then in Hippocrates, projections of the non-pay, non-drug component of unit costs are based on projected inflation rates, and they're projected to be around 1.6% per annum in the recovery scenario, 1.4% in the delayed recovery scenario. And now in the next presentation, Conor will describe how these inputs are used to project hospital care expenditure.